All right. So with that, I would like to introduce Marcia Colburn, who is the project officer for the Rural Allied Health Network Training Program, and she's going to introduce our first speaker. I hope I didn't put you on the spot, Marcia. Well, maybe I will go ahead. Our first speaker is Allison Hutchings, and she is with the Federal Office of Rural Health Policy. Are you with us, Allison?
Yes, I'm here. Can you hear me?
Thank you. We can.
Okay, great. I'm happy to get started and just give a brief overview of an upcoming funding opportunity that may be of interest to all of you. So I work with Marcia Colburn in the Federal Office of Rural Health Policy. In fiscal year 2018, our office received about $100 million for a new rural communities opioid response program. And so we are in the process of rolling out the first kind of phase of that initiative as we speak. We released a funding opportunity on June 15th called the Rural Communities Opioid Response Program Planning. It's in grants.gov as HRSA 18116. And there's a link to the Notice of Funding Opportunity on the slide under more about this funding opportunity. So just to give a brief overview, because I know you all have a lot of ground to cover during the webinar. This opportunity is $200,000 for 1 year, and we're anticipating making approximately 75 grants to high-risk rural communities. So the funding goes directly to communities, not through the state or through other channels. So the applicants can be any domestic, public, or private entity, nonprofit or for-profit. The lead applicant must be a part of a consortium or a part of a group of partners that have either committed to forming a consortium or a part of an established consortium. And the members must be separately owned, so have different employment identification numbers. So while the lead applicant and consortium members can be located in rural or urban, the target population must exclusively be in a HRSA designated rural area. So all that information is included in the eligibility section of the Notice of Funding Opportunity, so encourage you to look through that. You know, the focus of the grant is very much on planning versus service delivery. So it's an opportunity for, you know, groups of organizations to come together and develop plans for addressing opioid use disorder in their communities, and they can focus on prevention, treatment, and or recovery initiatives. And then the hope is that after the 1 year of planning that they're able to leverage additional funding, you know, whether through HRSA or other sources to actually implement those plans after the 1 year. So definitely encourage you all to check it out. We are holding a technical assistance webinar for applicants tomorrow from 1 to 2 p.m. Eastern. And that information is included in the Notice of Funding Opportunity on one of the first pages. It's like page II. And so if you're unable to make it, we will be recording it, and there's audio playback information there as well. And that'll really provide an in-depth overview of the application and what's required, and it's also an opportunity for you to ask questions. If you have questions in the meantime, or if you think of questions after the technical assistance webinar tomorrow, you can contact our opioid inbox anytime. It's rural opioid response at HRSA.gov, and we try to get back to you right away. So the application deadline is July 30th, and so just encourage anyone who's interested to get started, and definitely, you know, don't hesitate to ask questions. And then I have one more plug. So we are anticipating a lot of interest in this program, so if you aren't anticipating actually applying for the opportunity, but you have expertise in rural health and or mental behavioral health, encourage you to register to be considered to become a reviewer of the applications that we'll be reviewing. We definitely need a large number of reviewers. We anticipate the reviews are going to be occurring probably in early September. They're held remotely over a period of a few days, and reviewers who are non-federal and complete their assigned duties receive an honorarium. And so you can go to that link to both learn more about what being a reviewer entails and also to register in the reviewer system. So that's about it from me. Like I said, please direct any questions to rural opioid response at hrsa.gov, and encourage you to check out the link to the Notice of Funding Opportunity, which contains the information about the technical assistance webinar tomorrow. Thank you.
Great. Thank you so much, Allison. That was some really important preliminary detail for this really important funding opportunity. So thank you for being with us this afternoon.
Absolutely.
So next, I want to introduce our I guess you would call them a panel of speakers. We're so lucky to have with us this afternoon on the call. We have Captain Sophia Russell, and she is the Director of the Division of Nursing and Public Health with the HRSA Bureau of Health Workforce. Along with her, we have Melissa Moore, and she is the Behavioral and Public Health Branch Chief within the Division of Nursing and Public Health and HRSA HRSA Bureau of Health Workforce. And then, Alicia Langhorn, and she's with the Health Careers Pipeline Branch Division of the Health Careers and Financial Support with the HRSA Bureau of Health Workforce. And we will have bios for all of them that will be loaded onto our website, along with the link to the webinar recording and all of the PowerPoints from today's presentation that will come shortly after the call, within a couple of days after today's webinar. So I thank you so much, the three of you, for giving us some of your time today and sharing with us some of your expertise around network opportunities to the opioid epidemic and also behavioral health workforce shortages. So right now I'm going to switch to our first set of slides, and I'm going to turn it over to Captain Russell and also Melissa Moore.
Well, good afternoon. Thanks so much, Angie. And before getting into the details of our behavioral health programs, which Melissa Moore will have that presentation part, I would like to highlight the vision and mission of HRSA's Bureau of Health Workforce, affectionately known as BHW, where the behavioral health programs reside. So first, our vision seeks to realize the full potential of combining grant awards, loan repayment, and scholarships with health workforce research and programs that emphasize the links between education, training, and service. Hold on just a moment. The advancing of the slide, are we? Angie, just a quick question. And
yeah,
am I to advance the slides as well? I do apologize. I'll go ahead and advance the slides.
I can do it for you, or Melissa can.
I will go ahead and, okay. I apologize for that. So we're on the slide number 2. 2, that is Bureau of Health Workforce for everyone, and I do apologize for the slight mix-up. So I want to go back and talk about what our vision seeks, and it seeks to realize the full potential of combining grant awards, loan repayments, and scholarships with health workforce research and programs that emphasize the links between education, training, and service. And to fulfill this vision, the Bureau has to be creative about the way we do business today. And this is true in the way we shape the conversation about the National Health Workforce Policy, the way we manage funding opportunities, and the way we operate between the Bureau and the communities where service is provided. This slide, the Bureau of Health Workforce, our approach provides or is a strategic coordination and alignment and enhanced communication between HRSA's workforce programs to address shortages in underserved areas and develop ongoing strategies to monitor, forecast, and meet long-term health workforce needs. Our approach starts with research and data. We track national trends and examine issues that impact supply and demand, distribution, and preparation of the nation's health workforce. Informed by research, we address these trends by developing responsive programs and health workforce policies, applying resources to where gaps and needs exist. Our key focus areas include telehealth, rural and underserved populations, and community-based training. And this assists in guiding our approach as we create programs and funding opportunities which leverage academic and community partnerships to provide health professionals to address existing as well as emerging public health issues in underserved communities. We also build capacity by expanding training and practice environments to deliver coordinated, multidisciplined, team-based primary care, and enhance health outcomes by promoting value-based care centered on innovation, efficiency, and effectiveness. Following this approach, the Bureau of Health Workforce works to create a well-distributed and robust workforce supply of diverse, culturally competent health professionals who provide quality health care to communities in need. As a responsive, highly skilled workforce, we strongly have that as our core to BHW's work. So a strong healthcare system in our nation is at the core of the Bureau's work. Our programs reflect what we call the education and training to service continuum. We place emphasis on training culturally competent providers, distributing them to high-need areas, and retaining them beyond their service obligation, we hope, for their entire career. We invest in training that leverages changing provider roles and incorporates new models of care such as community-based training and integrated health. We also support trainees from disadvantaged and or underrepresented backgrounds, expanding the healthcare workforce to meet our nation's diverse needs, including for rural, minority, and elderly Americans. There is a recognized gap that exists between the demand for primary care services in the U.S. and the capacity of our healthcare system to meet that demand. We factor in these trends as we create opportunities for providers to train and practice in rural and underserved areas. This is critically important since research demonstrates that individuals who train in high-need areas are more likely to work and practice in these same communities after completing their training. We also develop programs that serve as a catalyst for advancing innovative changes in health professions, training, and practice. Our programs encourage team-based and integrated healthcare delivery and promote the use of new technologies and service delivery methods such as telehealth. These activities are investments that modernize our nation's health infrastructure, improve public health, and expand access to quality health care services for everyone, especially vulnerable Americans. The Bureau of Health Workforce's programs increase the nation's access to quality health care by developing, distributing, and retaining a competent health workforce. BHW supports more than 40 programs that recruit, develop, distribute, and retain the health workforce pipeline. We do this through providing more than $1 billion annually in grants, cooperative agreements, loans, and/or scholarships to more than 8,000 organizations and individuals. Every year, our programs serve millions of people, including people living with HIV and AIDS, pregnant women, mothers, and their families, as well as those otherwise unable to access health care. So that's a overview of the programs that the Bureau of Health Workforce oversees. And at this time, I'll turn it over to Melissa for the behavioral health portfolio. Thank you, Melissa.
Sure. Thanks, Captain Russell. And yeah, that's a really great overview of the Bureau of Health Workforce and how we structure all of our programs within the Bureau of Health Workforce. Now I'll cover a couple of programs that are specifically geared toward behavioral health workforce to help you understand the work that we're doing there and where we're taking this focus as we move forward. So integrating behavioral health services into primary care settings is a promising, a viable, and efficient way of ensuring that people have access to the needed mental health services. What we find is that that kind of integration results in increased access to care and improved patient care experiences. It also helps to improve health and decrease the risk of adverse outcomes. And it's associated with lower healthcare costs due to reductions in high-cost episodes because of greater access to primary care, a lower duplication of services, and a better coordination of follow-up care. So in fiscal year 2017, we, the Bureau of Health Workforce, awarded about $70 million across the 3 behavioral health workforce programs that you see on your screen, where we say select programs. We have 3 programs: the Behavioral Health Workforce Education and Training Program, the Graduate Psychology Education Program, and the Nurse Education Practice Quality and Retention Program, where we focus on interprofessional collaboration and behavioral health integration. So as Captain Russell indicated earlier, we're really focusing on this education to training continuum. These 3 programs are taking students in their final year of schooling, many of them master's or doctoral level programs in behavioral health, and placing them in rural or medically underserved communities to provide behavioral health services in integration with primary care coordination or primary care organizations. In 2017, these 3 programs that you see on the screen that I just mentioned trained more than 10,000 students per year. They serve about 25,000 individuals at about 3,000 different training sites. So these programs are quite robust and far-reaching. Nearly 2/3 of these clinical training sites are located in what we define as medically underserved communities. All 3 of these programs do partner with HRSA's funded federally qualified health centers. And when we connect with the students that are participating in these programs, most graduates indicate that they intend to continue to work within medically underserved communities or primary care settings. So we do truly feel that these programs are recruiting into service students that then are retained within those areas. So if we then take this as our foundation of behavioral health, and let's talk about opioids. You know, over the past 7 years, as you all know, the number of opioid deaths has increased substantially, including the rate of overdose death rates involving opioid pain relievers and heroin. This effect is especially evident in geographic areas with large rural concentrations of the United States, where non-medical prescription opioid misuse remains a really significant and growing public health problem. To address these issues, some of the things that we've been seeing and hearing are that the role of peer-based services in the treatment of opioid use disorder and models associated with utilizing peer providers are growing rapidly in the mental health service arena, particularly for those with co-occurring psychiatric and substance use disorders. These paraprofessionals or peers provide really critical support from a variety of different settings, and so they're able to address more of a social determinants of health and access all areas of a patient in terms of community organizations, medical settings, emergency departments, addiction treatment programs, primary health care facilities, criminal justice system, schools, and the child welfare system. The need for behavioral health paraprofessionals with expertise and skills to work with this population in creative and innovative ways is extraordinarily important. In the fiscal year 18, under the omnibus appropriations that federal agencies received, we, BHW, and DNPH did receive additional funding to expand training for the behavioral health workforce, our programs, to address the prevention and treatment of opioids and substance use disorder with an emphasis on rural and underserved communities. In May of this fiscal year, a month or two ago, HRSA did announce a competitive supplement for one of our grant programs, the BWET program. We have 136 grantees under that program right now. Our competitive supplement was to train those students in BIPIC, federally funded health centers, to create and develop coordinated care teams to address opioid use addictions. That funding opportunity is open right now through next Friday, July 6th. It is limited to existing BWET grantee recipients, so any of the 136 are open for this competitive supplement. But we are also actively working internally to develop additional programs to address this public health crisis. And as Allison indicated earlier, you know, she shared a website within Rural Health. I would also indicate HRSA has a broad opioids page. If you just do hrsa.gov/opioids, that would be a nice place to go to look at HRSA programs at large that are focused on opioid and how HRSA is responding to that. So just wanted to flag that for you. And finally, with really sort of focusing back on rural health and sort of where we see rural health, particularly as we talk about opioid use, we are looking at how do we utilize our new service delivery models to effectively impact the kinds of care that are provided in those areas that may even have a higher impact and or more difficult to develop a network to treat those areas. I know telehealth is something that's been utilized a lot in a variety of different programs, and we really are looking at how can we use telehealth capabilities or other novel capabilities to not only train and supervise the students, but then what is the role of telehealth in the provision of services in the long run. And so that's something that we continue to work toward to better understand how we can effectively use that to meet a gap within the service model. I will leave it at that and turn it over to the next speaker, and both Captain Russell and I are happy to entertain questions at the end of the call.
Great. Thank you so much, Captain Russell and Melissa. So at this point, I'm going to turn it over to Alicia.
Thank you, Angie, and thank you, Captain Russell and Melissa. I appreciate your good lead-in. So happy Wednesday, everyone. I want to acknowledge my colleague, Lorena Brayboy. She's on the line, and she'll be jumping in as well when we have some questions at the end. All right. So for today, my presentation will focus on an overview of the AHEC program, the AHEC Scholars Program, which I think will be of particular interest to this network. We will talk about the opioid-related activities that the AHEC have been involved in, our strategic partnerships, and in those two items, we'll look at some of our AHECs that we think are doing a great job, and then we'll have questions and answers together with previous presenters. Originally established by Congress in 1971, the Area Health Education Center program is authorized under Section 751 of the Public Health Service Act. The AHEC program aims to develop and enhance education and training networks within communities, academic institutions, and community-based organizations. These networks support BHW's strategic priorities to increase diversity among health professionals, broaden the distribution of the health workforce, enhance healthcare quality, and improve healthcare delivery to rural and underserved populations. Some of you may be aware the AHEC program recently underwent a redesign. So we currently have 49 AHEC program awardees and 261 regional community-based AHEC centers. And the AHEC centers are where most of the work is actually being carried out. The centers operate in 46 states as well as the District of Columbia, Guam, and the Republic of Palau. The target populations include high school students, grades 9 to 12, undergraduate students, health professional students, and practicing health professionals. The current project period is September 1, 2017 to August 31st, 2022. We're at the end of the first year of a 5-year cooperative agreement. As I mentioned a few seconds ago, the AHEC program underwent a comprehensive redesign, and we decided to streamline our areas of focus around our distribution, diversity, and practice transformation. There are 7 pillars in which we hang our hat and focus all of our work. The first is the structured AHEC Scholars Program. The AHEC Scholars Program is a program that all grantees must develop and implement. They must develop and implement a longitudinal interdisciplinary program curricula that implements a defined set of clinical, didactic, and community-based training activities in rural and or underserved areas, targeting students enrolled in health professions degree programs or allied health workforce programs. Upon completion of the AHEC Scholars Program, the scholar will have specialized training in rural and underserved populations. Oftentimes, many of those programs have a clinical component or a field-based practicum, and those students all work together and participate in different areas. There are 6 core topic or educational areas that they focus on. Interprofessional education, also known as interdisciplinary training, that supports a coordinated patient-centered model of healthcare that involves an understanding of the contributions of multiple healthcare professionals. There's a focus on behavioral health integration, which promotes the development of integrated primary and behavioral health services to better address the needs of individuals with mental health or substance use conditions. Focuses on the social determinants of health, which includes 5 key areas: economic stability, education, social and community context, health and healthcare, and neighborhood and built environment, and their impact on health. There's a focus on cultural competency, which seeks to improve individual health and build healthy communities by training healthcare providers to recognize and address the unique culture, language, and health literacy of diverse consumers and communities. Think about the national standards for culturally and linguistically appropriate services in health and healthcare. And then the other 2 pieces are practice transformation, which aims to fully support quality improvement in patient-centered care through goal setting, leadership, practice implementation, workforce changes, measuring outcomes, and adapting organizational tools and processes to support new team-based models of care delivery. Educational and training activities should target their specific skills and competencies needed to prepare students and practicing health professionals to effectively practice in a transforming healthcare system. And then finally, we allow our grantees to focus on whatever the current and emerging health issues are. In the past, it would have been the Zika virus, pandemic influenza. Now, of course, the opioid epidemic, geographically relevant health issues were also proposed. So they're allowed to have some stable ones, and they're also allowed to be very specific in response to the needs of their specific community. So the third pillar is strategic partnerships. And this is where they have to engage key stakeholders at a federal, state, local, and national level, and different organizations that will work with them to advance and sustain the AHEC program and maximize the impact and outcomes like some of the primary care associations, the state offices of rural health, the health centers, critical access hospitals. It's very broad and very wide. And then we've implemented a statewide evaluation activity. As I mentioned earlier, there are 49 different states, but sometimes there are oftentimes multiple AHEC centers and even sometimes multiple AHEC program offices within the state. So to quantify the impact of our grant investment, the grantees must implement a comprehensive outcome-focused evaluation of the AHEC program activities, of all of the AHEC program activities. The AHEC program officers and the grant recipients had to develop and implement a statewide evaluation in collaboration with the AHEC centers to ensure that consistent evaluation tools and protocols are used throughout the state. And then the fifth component is the community-based experiential training. Grantees must support community-based experiential training in rural and underserved areas. Through field placements and clinical rotations, they must be team-based and include a formal didactic component that addresses one or more of the core topic areas I mentioned earlier. And then our last two pillars are the pipeline activities and continuing education. Pipeline activities focus on that target population of high school students grades 9 to 12. Where we focus on exposing youth to health careers, including public health. We strongly encourage our grant recipients to use no more than 10% of their funds for those activities. And then the continuing education is where grantees support didactic and experiential training activities, also focus on the core topic areas for currently practicing health professionals. It is also strongly encouraged that they use no more than 10% of the award for those activities. So that's how we streamline the program to focus on those three core areas of distribution, diversity, and practice transformation. So the area that we believe that was one of our key networks and our key network opportunities that we're talking about today is the AHEC Scholars Program. And the HRSA AHEC, the AHEC Scholars Program is a HRSA branded interprofessional education program. It includes a longitudinal program, which I mentioned earlier, with the interdisciplinary curriculum. So students, while they are in school, are being exposed not to just their expertise, but other health profession areas that they will also be working with. It has community-based experiential clinical training that occur in rural or underserved areas. All grantees have to have at least one cohort of AHEC Scholars Program that must last at least 2 years, and stipends are allowable for students that are in these programs. Diverse students are gathered together in a cohort, and they have to have representation from disadvantaged backgrounds and also underrepresented minorities. That's how we start to fuel diversity. The establishment of strategic partnerships helps support the successful implementation of these programs. At a minimum, these programs are designed to be 2-year programs as it relates and correlates with the students and where they are in their particular program. They have to get individual data on program participants with required 1-year post-completion data on employment outcomes. One of the key focuses of this is behavioral health integration. So anybody that has an AHEC Scholars designation will have a focus on behavioral health integration as a part of, and have some almost certification or some enhanced skills in that particular area. We believe that leveraging the AHEC Scholars Program is one of the keys to addressing the opioid epidemic. So this next image is a depiction of our new or enhanced AHEC model. And as you'll see, it is a bidirectional relationship between the AHEC Program Office and the AHEC centers. We believe that will allow for better coordination and communication between the program offices and the centers. We believe it will increase the accountability and guidance from the program office through the statewide evaluation and AHEC Scholars curriculum development. So instead of there being 5 or 6 different AHEC Scholars programs in one state, that all of them that are in one state will be going through the same process. The AHEC Scholars Program produces healthcare providers with specialized training in community-based, rural, underserved areas. And I think if you heard one of the other speakers talk about, we really believe exposing clinicians or health professionals to working in rural, underserved areas will more likely help them to stay in their area once they are actually certified and they want to specialize. They'll already have experience and be more likely to be retained. The interprofessional education team-based training provides patient-centered models of healthcare, practice transformation, high-quality care, and transforming healthcare delivering systems. We want to leverage and build strong strategic partnerships. Collectively, we believe this model and these activities that we focus on will maximize the program's impact and outcomes. Driving innovation. We believe there are a few things from the AHEC program in the current state that will drive and will help enhance innovation. The first, of course, is the AHEC Scholars Program. A few grantees are already piloting their program. In Hawaii, University of Texas in San Antonio, in New Jersey, they are finalizing their curriculum, their admissions process, and identifying community-based clinical sites for their program. Some AHECs are modifying their already established similar programs and have created their AHEC, and others have created brand new AHEC Scholars Program from the ground up. One of the requirements throughout the planning period is the submission of multiple progress reports and technical system webinars in which the HRSA program officers are able to work hand in hand with the grantees at this point to implement the program. One of the other things that we think is driving our innovation is the fact that the AHEC program has to have representation on the admissions committee for the School of Nursing or the School of Medicine or the School of Nursing where it's applicable. We believe that this will bring more visibility to the AHECs within the medical school and give the AHEC program directors a voice at the table to bring attention to students who are from rural underserved areas and promote a holistic approach to admission. We understand that while the AHEC program directors don't control who's admitted into the School of Nursing or Medicine, we believe they can at least bring some topics and some individuals to discussion. They'll help remind admissions committee about how important it is to have students that are from rural underserved areas who will be more likely to go back to those areas to be able to face some of the different emerging epidemics that we're addressing. Strategic partnerships. Let me highlight a few organizations that are already working and building up their AHEC Scholars Program. And because of that, they have been already invited to do to share their best practices and learnings learned. And they've been working in some learning collaboratives like the Northeast Learning Collaborative. They will be using an evaluation framework centered on the competencies, and the Texas AHEC will be using the collective impact model. So the AHECs have been nationally recognized for their initiatives and programs regarding health topics such as opioids, telehealth, and health literacy. This has been demonstrated by they being asked to present on Project ECHO programs like for the National Rural Health Day and being invited to collaborate with the National Academies to contribute to a book on health literacy innovation. The AHEC program was a part of the first ever federal roundtable on workforce pipeline program. The roundtable brought together our Indian Health Service, SAMHSA, Department of Labor, Administration of Children and Families, Department of Education, Office of Minority Health, and Office of Minority Health counterparts, together for a discussion on how we can leverage our resources and work more cohesively with federal partners. We've also collaborated with other branches and divisions to encourage partnerships with AHEC with other program notice of funding opportunities such as the Primary Care Training Enhancement Training Primary Care Championship notice of funding opportunities. With this being a planning year, AHEC POs have also seen AHEC grantees expanding their strategic partnerships with other health professionals within their academic institution, community colleges, primary care associations, and community-based organizations. Despite these innovations and opportunities, there have also been some challenges that we'd like to mention. Becoming an AHEC scholar has been difficult for AHEC centers in rural and frontier communities, where there are limited infrastructure, limited health professional schools, and a limited number of health professionals in the community, and the difficulties in transitioning from the youth pipeline to the AHEC Scholar Program. We know, of course, that there's a limited number. This has increased the number of preceptors available and the need for preceptors available in community-based settings and the need to update data to establish the implement systems for tracking and post-employment monitoring. But we believe that even though we have these new advancements, of course, as you move forward to be innovative, there are definite challenges that come about. But our AHECs have definitely risen to that challenge and are finding innovative ways to address them. So some of our opioid-related activities are two that we like to highlight come from the Vermont and the Nevada AHEC. In partnership with the state of Vermont, the Vermont AHEC Program Office promotes the prescription drug monitoring system that helps track the prescribing and dispensing of controlled substances throughout the state of Vermont. The Office of Primary Care and Vermont AHEC continue to disseminate improving opioid prescribing, solutions for Vermont Fast Track, Practice Fast Track, and Facilitator Toolkit to assist providers in managing opioid prescriptions in primary and ambulatory care settings. They work for prescriber education and quality improvement, QI. As an innovative activity, the Vermont AHEC has been developing and delivering QI programs to practice in the topic areas of opioid prescribing. These programs are evidence-based and use data from statewide or practice sources to measure impact and to close the QI feedback loop. There is still a significant need for further training and pain management for many members of the healthcare team in primary care, but it's one step, we believe, in the right direction. The Vermont AHEC also serves as mentor and advisor to 7 second-year medical students on a public health project about prescriber perspective on Vermont's new opioid prescribing rules that went into effect July 1st, 2017. A poster and abstract were finalized and presented on January of this year. That abstract was submitted to the American Public Health Association's annual meeting.
Anything for you? Yeah.
Excuse me, I'm going to interrupt for just a second. Excuse me, this is Angie with RHI, and we're getting a lot of background noise, and we're hearing some paper shuffling and some voices. So if everyone could please double check to make sure that their phones are on mute.
Thank you
so much, Alicia. I'll turn it back to you.
No problem. And one of the other teams in Vermont has a team that includes a medical student and a resident who presented 2 abstracts regarding population management of opioid prescribing at the Society of General Internal Medicine annual meeting in April 2018. The Vermont AHEC sponsors and collaborates on interprofessional continuing education programs and is currently planning to conduct a statewide interprofessional primary care conference on Bridging the Divide, which brings together primary care and public health professionals to discuss major public health priorities within the state. They've offered some cultural and linguistically competency. It was offered in January of this year, and 5 additional sessions were planned for March. And we're just giving those as examples of how working with students, public health students and medical students in particular, have led to more information being distributed among other providers and other soon-to-be providers. In Nevada, the AHEC Scholars Program has a behavioral health didactic and clinical material where they address behavioral health through collaboration, distributed, and ethical leadership. They use Project ECHO. It's called ECHO's Behavioral Health and Primary Care, whose goal is to enhance the skills of primary care providers in assisting the behavioral health needs of patients, improving their skills in non-pharmacological primary care interventions, and to assist in the creation of a local or regional referral network. Furthermore, the ECHO Professional Development Group allows mental health professionals to consult with the University of Nevada in Reno medical faculty on specific de-identified cases, which are then used to educate the larger provider community. I'm just showing that as an example for how we started kind of locally on some of our AHEC sites, and it's built up nationally, and then the Vermont gives you a sight of how something started at the state level, and then they've helped us filter it down to the local level. And then let's look at our last slide and talks about the AHEC and their use of strategic partnerships. So in western Montana, they are also a recipient of HRSA's BWET, the Behavioral Health Workforce Education Training Grant, which Melissa Moore and Captain Russell spoke so eloquently about. Their task is to meet weekly with faculty from the 4 participating departments: psychology, social work, counselor education, psychiatric nurse practitioner, and 3 participating organizations: the University of Montana, Montana State, and the Western Montana AHEC, in order to coordinate field placement. They have developed 7 training sites that have been contracted, are in the process of being onboarded. 15 students have already applied and are in the process of being onboarded. This inaugural year included the onboarding of those sites and the students simultaneously. Of course, in the future, they don't want to have those things happening together. Students will be allowed to complete the required IPE course online to accommodate their busy schedule, so they'll be prepared to and already have some of the fundamental learning they need to participate in these coordinating teams in their field placement sites. The Montana AHEC mentioned some of their